Good evening and welcome to our virtual annual general meeting and annual members meeting, which our chair David Walker will officially open very shortly. My name is Sarah Taylor and I'm the head of the communications team which is supporting tonight's proceedings. We would appreciate your patience and understanding if we encounter any technical glitches along the way. There'll be plenty of opportunities to ask questions of our panelists when the time comes. And you can do so using the Q&A function on the top right hand side of your screen, which will be illustrated here very shortly. We do hope you enjoy this evening, and I know our chair David Walker is keen to get underway. So without further ado, let me hand over to him now. David, over to you.
Thank you, Sarah, and welcome to this annual general meeting and annual members meeting for Oxford Health NHS Foundation Trust. Before we go on, I do need to pay a tribute to Sarah, Anushka and colleagues in the communications team who've made this event possible. Sometimes people focus rightly on the front line of NHS services, and they're sometimes a little sort of dismissive of the back office. But without the back office, many important functions wouldn't happen, and communications, I have to say, is one of them. So thank you, Sarah and colleagues, for making this event happen. We've got two purposes this evening. One is accountability. Clearly, in a formal sense, the members and governors of the trust have to hold the board through the non-executive directors accountable for our expenditure of public money to secure health services in our area, and that's a vital function, and we'll hear in a few minutes from the external auditors who are appointed by the Council of Governors to oversee how we do spend that public money, a vital function. Facts and figures need to be presented to you. You, the members of the trust, need to approve the accounting that's laid before you, just as our accounts are put in front of the Houses of Parliament and have to be approved by them, and in a sense virtually through you and through Parliament by the public whose tax monies support our activity. So receiving your approval and perhaps your criticism and questions about what we've done with that resource is an appropriate thing to do this evening. But I hope also we'll have a moment to celebrate. A lot of good things has been done by the NHS in trying circumstances over recent times. You'll hear about some of them this evening. I won't go into them now, simply to observe that our colleagues have worked very hard under great strain. Wearing protective equipment is not easy. Dealing with patients who themselves are worried, sometimes directly afflicted by the virus, adds to the difficulty of the task. So there's a lot to celebrate. I hope you'll agree with me about that. Now, that's pretty much all I'd like to say. Just briefly, perhaps, we spent some time today earlier as directors looking at how we do function as a board, and I was very happy to have 5 minutes during that to present to Marie Crofts, our Director of Nursing, a token certificate of recognition from the NHS about how well this trust has done in terms of infection prevention and control. Not to be complacent, pandemic isn't over, lots and lots of issues ahead on that front, but I think it's worth pausing to reflect just how well, again in very difficult circumstances in terms of supply and utilisation of infection control equipment. You'll remember the problems we had back in March and April of last year, how well the trust has done. So congratulations particularly to Marie, the nurses, but also of course to our other clinicians, our allied health professionals and doctors. Now, about to start in this early autumn, a new cycle of meetings and activity in the trust. Lying ahead, we've got the vaccination program for flu, for our staff, the public, booster vaccinations, again for our staff and for the public at large. We potentially face a visit this autumn from the Care Quality Commission, looking at how whether we are indeed well led, to use their phrase. Before next April, April 22, we have major work of integration to effect in terms of the integrated care system to which we belong, Buckinghamshire, Oxfordshire and Berkshire West. And again, I'll repeat, a lot of work to do in terms of developing the board to make it the board that is leading an outstanding trust. We want to be, on your behalf, an outstanding board to help our colleagues who deliver the services be outstanding on behalf of our patients. Now, again, I repeat, making sure we do that is part of the function of the governance structure that we've got, our governors and members. I hope this evening we'll have a sense that we are all pulling in the same direction, trying to reach similar goals, the primary one of which is to better serve those patients, those people who come to us in some need. Enough for me. I hope I haven't gone on too long. I'd like to hand over now to the Chief Executive of the Trust, Nick Broughton.
David, thank you for that, and thank you to everyone who has joined our annual members meeting this evening. The fact that you are interested in the organisation is much appreciated, and the fact you found the time to join us tonight is hugely appreciated as well. This is my second annual members meeting. I joined the Trust in June last year. Indeed, the photograph you've just seen of me was taken, I believe, during my first week in post, when we were coming out of lockdown and hairdressers were still closed. Some may say my hair hasn't improved much since. Stating the obvious, the last year was extremely challenging for Oxford Health and everyone working in it. We continue to face considerable challenges related to the COVID pandemic, including a significant demand on many, if not all, of our services. And the pandemic impacted personally on virtually everyone working across our organisation. As Chief Executive, I am incredibly proud of how we coped with these challenges as an organisation and of the care we continue to provide to literally thousands of people who use our services and indeed often rely on the care that we provide. It's undoubtedly been a team effort, and everyone across Oxford Health has played their part, as David has already indicated. Our frontline clinicians from all disciplines, not just doctors and nurses, but a whole range of allied health professions, social workers, psychologists, have been supported by a wide range of other professionals in many other services, whether it be information management and technology, estates and facilities, human resources, administration. I could go on. And whilst on occasions the care we have provided has not always been as good as we would have liked it to be, in the vast majority of cases it has been good and helped transform many, many lives. And if we can have our first slide, please. It's up already, excellent. So this just gives you a flavour of the volume of activity and the sheer numbers of patients and service users who we have supported and cared for over the last year. As you'll see, we provided well over 1.3 million individual patient contacts, and it should be remembered that we've done this over a large swathe of the south of England, with our services extending from the M25 in the east to North Somerset in the west. And I believe the fact we've been able to maintain this level of activity is a considerable achievement. It's obviously a reflection of the commitment of our staff, but it's also a consequence of our ability to innovate and embrace new technology. I would particularly like to highlight the increase in our use of digital consultations, which we've used alongside face-to-face care. This increase, I think, has been quite extraordinary, an example of how Oxford Health has led the way regionally and indeed nationally. We are using more digital consultations than virtually any other comparable trust in the country. Another example of the role we've played in our ability to lead and innovate has been the vaccination program for COVID-19 and our role as the lead provider for this program across Buckinghamshire, Oxfordshire and Berkshire West. I don't intend to steal Tamina's thunder. She's led this program amazingly well, and you'll be hearing from her later. Suffice it to say, we have been instrumental in delivering what has been one of, if not the most effective programme in the south of England. Whilst the pandemic has brought with it many challenges, those challenges, I believe, have helped us improve and strengthen as an organisation. Communication across the Trust has certainly improved through a variety of initiatives, including regular webinars not dissimilar to tonight's meeting, and I believe we're certainly a more connected organisation as a result. Our relationships with partner organisations have also been strengthened, and we've developed a far stronger culture of collaboration, working with our local authority colleagues, our neighbouring trusts, and a wide variety of other organisations, and of course primary care. I always find an annual members meeting an invaluable opportunity both to reflect on the challenges and indeed successes of the year gone by, but also to look forward and consider what the future may have in store. And I'm certainly very optimistic with regards to the future of Oxford Health and what we can achieve as a trust. During the last year, we have produced a new 5-year strategy and revised our vision. So if we can have the next slide, please, that'd be great. And as you'll see from this, our vision now reflects the importance of teamwork in everything we do, something which has been repeatedly highlighted during the course of the pandemic. We've also developed 4 strategic objectives. And next slide as well, thanks. These focus on improving the quality of care we provide, on our people and ensuring that we are a fantastic place to work, an organisation that grows its workforce and supports its workforce, an organisation that's focused on sustainability, not just ensuring that we manage our finances well, but we do our part in terms of reducing our carbon footprint and meeting the climate change challenge. And of course, research and how we can become a leader in both research and education. Achieving these priorities will be now our absolute focus. And if we can do this, which I believe we can, we will become a truly outstanding trust in every respect. We have, I believe, a firm foundation on which to build, not least our workforce, which includes many exceptional individuals across all professional disciplines. We also have the benefit of strong relationships with a wide variety of academic partners, especially our local universities, and you'll be hearing some more about that later this evening. The fact that we host one of only 2 biomedical research centres in the country that's focused on mental health is something that we are really proud of. And as we look ahead, we are hopeful that we will be successful in securing a significant increase in the funding for our BRC, which will enable us to greatly expand research, not just across our trust, but across a wide swathe of the country, looking north towards Birmingham, Newcastle and Liverpool, for example. Today's research is tomorrow's care, and we see the development of a strong and pervasive research culture throughout the Trust as an important way we can continue to improve the quality of care we provide to those who use our services. And we're very aware that our patients and service users want to be involved in research and the benefits it brings to them in terms of their overall experience of our services and our care. We're also very aware of the importance of providing services and delivering care from buildings that are therapeutic and enable our clinicians to work to the best of their abilities. With this in mind, it was fantastic that we have been able this year to consolidate many of our mental health services in South Buckinghamshire in a new building. So continuing to progress and develop our plans to build a new mental health inpatient unit on the Warneford site, and for this to be part of a new brain sciences campus, sitting alongside a state-of-the-art research unit, and so enabling clinical research to be truly embedded in how we deliver care. Good healthcare is, I firmly believe, all about good multidisciplinary team working, and in recent times we have seen some important changes to the Trust's executive team. Carl Marlowe joined us this spring as our new Chief Medical Officer, and Charmaine D'Souza will be joining us on the 4th of October as our new Chief People Officer. In addition, it is with sadness that we will be saying goodbye to Debbie Richards in early October, who has been our Managing Director for Mental Health learning disabilities and autism for 2.5 years. We're very pleased, however, that Debbie will be becoming the Chief Executive of Cornwall Partnership NHS Foundation Trust, and the fact that she's taking on that senior position, I think, reflects well on Oxford Health and how we can develop talent. We'll be interviewing next week to identify Debbie's replacement, but she undoubtedly leaves large shoes to fill. In addition to what I believe is a great workforce, we as a trust are privileged to be supported by a wide range of other people who care passionately about the care we provide. And I'd like to formally thank our Council of Governors and our League Governor, who you'll be hearing from in a couple of minutes, our various leagues of friends that do amazing work to support our community hospitals in particular, all our members, everyone who's contributed to the Oxford Health charity, and of course, all those who use our services and care for those who use our services. We must continue to have an unrelenting focus on improving the care we provide you and the experience you have of our services. This must always be our absolute priority and the one thing that continuously provides our focus. We can't provide any care without money, and I now would like to hand over to another member of my executive team, Mike McEnaney, who is the Trust Director of Finance.
Thank you, Nick. Good evening, everybody. I'd like to just run you through the financial results for an accounts summary for the year ended 31st of March 2021. If you could turn to the first slide, please, and I'll take you through it. So I guess the most important thing, as already mentioned, is that the year was not a normal year, with COVID influencing many of the ways in which we had to work, and that, not least of all, affected the cost of working as well. So it cost us a lot more to work in the year than it would have done otherwise, due to social distancing and all these various aspects of having to deliver healthcare in such an environment. And you'll see at the operating income level, 426.8 million compared to 381.9. That's 12% increase, quite significant. I can say that around about 11 million of that was COVID cost related. So the income came in and went out as spend. We also put through here the costs, as it was mentioned, of running the vaccination centres. So the first 3 or 4 months of costs running the vaccination centres across Bob came through our account. So it's complicated the picture of what we have, but this is why you see these large increases, and you see in the expenses significant increase too. Operating surplus deficit 0.1 against 6.1. As usual in finance, it's not quite what it seems because there are revaluation figures coming through here, and I'll explain what the underlying performance is or was in a moment. The financing costs, you can see a reduction, particularly in the dividend, and this is part of the financing cost to the government, and this was largely due to a higher increase, a higher level of cash in the trust throughout this period, and therefore there was less cost to pay and interest to pay back to the government. And then you will see right at the bottom there, one of our accounting adjustments, we have to revalue the property, particularly property, plant and equipment that we hold has to be revalued annually, and this you can see the value went down, and so it ended with the actual accounts themselves showing a 6.3 million deficit compared to a 3.8 million deficit the previous year. I'll explain the performance bit in a little moment. Next slide, please. So the next one is the statement of financial position. So it's one half of a balance sheet. And here I'd just like to explain total non-current assets. Basically, that's property and systems and equipment. And you can see a slight reduction there. We did invest 9.5 million in the year. So there was significant investment in the year in systems and property and development there. However, the combination of depreciation, but also the revaluation downwards made net reduction in the asset value that we hold on our balance sheet. The other point I'd point out here is that significant, I should point out, is trade and other receivables, which is money owed to us, 13 million as opposed to 38.1 million. And this is reflected in the fact that we were no longer invoicing for NHS contract income. The income was being provided to us on a block payment basis, and therefore there was no outstanding debt to show. And you can see this reflected in the higher cash balance of 55.7 million, which puts us in a very strong position cash-wise. The borrowings is the final piece I'd mention here. Reduction there as we annually pay off some of the loan that we took out to build the Whiteleaf Centre in 2012. Next slide, please. In terms of financial performance indicators, working capital, this is the amount of money we need to run the business. That was in a better position than was the plan, so that's good. EBITDA, this is actually the operating finance performance, 9.9 million against 10.4 million, so just slightly down. But the key one here against last year is the adjusted financial performance. This is the true bottom line, if you like, was almost break even in the year, 0.2 million deficit, and compared with a plan of 1.8 million. So we actually improved upon our plan for the year. So that was a good result. Agency, as many people know, we have high agency costs, and you'll see that in the plan of 27.8 million. But that's been considerably exceeded, and this is down to the increased staffing for COVID support and also for the vaccination centres across Bob as well. And the final piece here is BPPC, which is the Better Payment Practice Code. This is, are we paying our invoices quickly and promptly? And we failed to hit our target of 95%. We have a plan in place now and are pulling back to that, but we missed the target slightly in the year. And that's all about processing payments more quickly and promptly to pay our suppliers. And the final slide, please. And this is just a quick outlook. So in the environment we're in at the present time, there are two main influences. One is COVID. So the first three bullet points, I'm not going to read through them all. COVID is still with us and the finance regime is still there. We don't quite know what the second half of the year will bring. That hasn't been confirmed yet. So we've got our finance plans, but we may have to adjust them accordingly. But it still has a significant impact. And the second one is integrated care systems, the ICS. And here it's just really important to understand the money coming to Oxford Health now or into any provider in Buckinghamshire, Oxfordshire or Berkshire West actually will come through the ICS, and they will be allocating the funding for healthcare across the area and the region. And so it's important that we are well integrated and involved with those developments. And then for Oxford Health itself, we are relatively efficient or have been. We plan to break even this year. This is our goal. We have cost improvement plans that are about 3.5 million this year, and they may have to increase depending on the finance regime that comes in the second half. Cash position remains relatively strong, or I'd say very strong in comparison to previous years, which is good. And just to note, the fact that we have these lead provider collaboratives, 2 of them live and 1 in the pipeline, means that we have additional finance to manage there. There is opportunity, but there's also risk. And our capital projects, we have a 12.4 million plan for this year, but any more than that is not available because the Treasury has very tight limits on how much we can spend. So that's a quick run through the accounts. Hopefully it wasn't too unintelligible, and we'll be taking some questions later. But I think I'm going to hand over now to our auditors, Grant Thornton and Iain.
Thank you, Mike, and thank you very much for having me along this evening. I always feel slightly sorry for accountants and auditors on an evening like this evening, trying to make quite unintelligible and often technically difficult things accessible. But I'll do my very best. And as Mark says, there's an opportunity to ask questions at a slightly later point this evening. If I could have the first slide, please. So our role as the Trust's external auditor is twofold. We have two things that we do for the Trust and two areas where we provide assurances to the board and to the Council of Governors. The first of those is around the accounts, so some of which Mike's just shared with you. And basically we give a view as to whether those accounts are correct, whether they're fairly stated and whether they are something that give a true reflection of the Trust's financial performance and the financial position at the end of March in 2021. The second thing we do, and this has changed slightly this year from previous years, but we also look at the arrangements that the Trust has in place. So we look at how the Trust is run and whether those arrangements are appropriate. And when we say appropriate, we're looking at making sure that the Trust isn't exposed to big risks in terms of financial loss, big risks in terms of the quality of the services that it delivers, but also big risks in terms of potentially unlawful actions and those kinds of things. So we issue, I suppose, we offer a view on two areas of the Trust's operation in our role as external auditor. If I could have the next slide, please. So when we look at the financial statements and we look at the accounts, as I said, we're looking at this true and fair view. As well as that, we're also looking at the other information, the other things that the Trust publish around those accounts. So the information included in the annual report and the information included in the annual governance statement. And we're looking at those to make sure that there isn't anything in there which is misleading or anything which isn't consistent or doesn't ring true with what we know through our work that we do with the Trust. And then finally, we're looking at whether there are any uncertainties around the Trust as a going concern. And what that means is whether the Trust is likely to still be around in 12 months' time. Unfortunately, we've had some common sense prevailing this year in that respect, and that's certainly a lot easier now than it has been historically. If I could have the next slide, please. So when we carry out our work, we use a concept or an idea called materiality. And basically, this is the level of error or mistake that we'd be able to accept within the accounts. And it's quite a big number, nearly £8 million. And there's two reasons for this. One is we obviously, if we audited to the penny, we'd be in all year. It would cost an awful lot of public money, and we'd be constantly under the Trust's feet as they were trying to get on with, as it was trying to get on with delivering services to its residents. And the second thing is obviously the Trust spends quite a lot of money, and so there is a degree of error and mistake which can exist in the accounts without necessarily making them wrong or making it so that someone reading those accounts gets an incorrect impression of what the Trust is saying about its financial performance during a year. If I could have the next slide, please. When we carry out our work, we identify a number of areas of risk. I won't go through each of these individually, but I think I could summarise these as saying, as auditors, one of the things that we're trained to be is sceptical. We're trained to challenge and ask questions of management because we're independent. We don't work for the Trust. We're there to make sure that what the Trust is saying is a fair reflection. And these four areas all are in relation to that. So we're looking at those parts of the accounts where the Trust has an opportunity to either change things or to potentially present things in a slightly better light than they might actually be. And those four areas were the four areas of significant risk which we identified in our audit this year. Next slide, please. There's a slight spoiler there, unfortunately, but the good news is that we issued an unmodified opinion at the end of June, and an unmodified opinion in audit language is a clean opinion, so that's a clean bill of health. We based on the work that we did, we were satisfied that the accounts that the trust had produced were a fair reflection of its financial performance and a financial position as at the end of March. If I can move on to the next slide, please. So the other area, as I mentioned, is looking at the arrangements that the trust has in place for value for money. This was changed this year. The National Audit Office, which set the framework for auditors in the public sector, changed their code of practice. And I don't think we could have chosen a worse year to introduce new arrangements with the coronavirus pandemic, but unfortunately those were the cards that we were dealt. This work covers 3 areas. So we look at financial sustainability, which is about money. That's about how well the trust manages its money now and how well the trust is planning to manage its money in the future. We look at governance, which is how the trust makes decisions, whether it's making decisions and the process, making good decisions and the process it goes through in making those decisions. And then we look at improving economy, efficiency and effectiveness, which is about how does the trust perform, how does the trust monitor its performance, and how does the trust look to make things better on a continued basis. If I could have the next slide, please. And I think the good news here is that across all of those 3 areas, again, we gave the trust a clean bill of health. We didn't identify any significant weaknesses in the arrangements, so nothing which we flagged as a big risk in terms of those 3 areas. And actually, whilst no organisation is perfect from our perspective, we didn't see anything in the arrangements where we needed to make any improvement recommendations, which are things we would point out if we thought that there were smaller things that the trust needed to put right. So again, on the value for money, we gave the trust a clean bill of health, and if people are interested, there's a more I think a more thorough narrative around each of those areas in our auditor's annual report, which we will be published on or is published on the trust website, and sets out in a bit more detail our considerations and a commentary on each of those 3 areas. As I said, there is an opportunity to ask me any questions, I think, shortly, and I believe I'm handing over to Mike Hobbs, who's the lead governor, for his review of the year. Thank you.
Thank you, Ian. Yes, so as he says, I'm Mike Hobbs. I'm lead governor for the trust. Next slide, please. It's my responsibility as lead governor to present to members a number of substantive amendments to the trust's constitution, and you'll appreciate that the constitution sets out the powers and functions of the trust and how its governance is operated. The changes that we will address here, next slide please, have been approved already by the Council of Governors and the Board of Directors. But the Trust's constitution requires that changes to the constitution are approved by the Trust's members. So the changes are listed here. I will set them out in turn briefly. If any member does not approve any one of these changes, please declare this in the question and answer facility, the chat facility as it's often known. Next slide, please. So the first change is in relation to the composition of the Council of Governors, and specifically this involves an increase in the number of service user governors from 4 to 8, 2 increased to 4 in Buckinghamshire and 2 increased to 4 in Oxfordshire. But partly in order to keep the council to a manageable size, this goes along with a reduction in the number of public governor positions from 4 to 3 in Buckinghamshire and from 7 to 4 in Oxfordshire. But we still retain the single public governor who is responsible for the rest of England and Wales. Thank you. So change 2 introduces a defined term of office for the lead governor, that's me currently, of up to 3 years, where previously there was no definition of the tenure of the lead governor. This is, however, naturally subject to alignment with the electoral process. For example, I have been a governor for just over 2 years now, so I've got slightly less than one of my 3 years, my 3 elected years to go. So I will need to be re-elected next year if I am to serve years 2 and 3 as lead governor, because I've only just taken on the role this year. Change 3 and change 4 refer to disqualification criteria for governors and directors. These amendments are needed to take account of changes in the National Health Service and in particular the introduction of integrated care systems. And specifically, governors will not now be disqualified from holding a governor position if they are a governor in another foundation trust or a member of this trust's patients forum. Next slide, please. Non-executive directors will not be disqualified if they are or become an executive or a non-executive at another foundation trust or another NHS body. Change 5 is rather different and refers to significant transactions and specifically to the inclusion within the Trust's constitution in the addendum entitled Engagement Policy of a description of the matters deemed to be significant transactions and which thereby require approval of the Council of Governors. And significant transactions include, for example, mergers, acquisitions, or the dissolution of the trust, or the separation of the trust into a number of parts. Next slide, please. As I've said, these changes, although approved by the Council of Governors and the Board of Directors, require the approval of trust members. So any member who does not approve of any one or more of these proposed changes, please make this known now in the question and answer column. If no objections are received, all these changes will be considered approved by this annual meeting. At that point, I'd like to hand back to our chair, David.
Thank you very much, Mike. Just to check that that approval has been registered. Yes, you're happy?
Yes, we haven't got any objections, Chair.
Very good. Now I'm going to hand over to the Fiona Bruce of Oxford Health in the shape of Sarah Taylor, who will compare a brief session to allow you to ask us, the people you've just heard from, any questions, raise any points you'd like with us. So Sarah, do we have any questions from the floor, as it were?
Yes, we do, David. We've got quite a few questions on coming through. I'm going to start with finance at the moment. We have a couple of questions here, both aimed at Mike McEnaney, our director. One is just to note, thanks Mike for a great up-to-date piece of information. How do we get this message through to all our staff?
There you are, Mike. A question about financial communication.
Yeah, so we're actually in communication with our staff a lot via all of the services and the directorates and through there. I mean, one of them is, of course, is budgetary control, and we have to manage it. But actually, we are in the fortunate position at the moment, particularly in the mental health area, that there is additional money coming through. So we are expanding the work we're doing and expanding the services. So there's good opportunity there. But we are always trying to balance the messaging between the excitement of new services and expansion, but also the need to actually always reduce the cost of what we do, because we will ultimately have less money to do what we do normally. This is the way the NHS efficiency regime works. So this is how we communicate. But it actually is very difficult. It's a difficult message to get across some of these complex, almost contradictory financial situations.
Sarah, what else we got?
We have another question about finance from a member called, or possibly a member of staff, Stefan Ivantu, who is asking, wonder if we need to have a more robust working capital greater than 2.5 million, given the current stress in the supply chains. Any thoughts?
Yes, I mean, it gets technical. Of course, working capital is made up of stock, debtors and creditors. And as you saw, the debtors, because we aren't invoicing for our services at the moment, just receiving the cash, it actually reduces the level of working capital and increases our cash, and cash isn't included in working capital. So it's a technical issue. Actually, we're in pretty robust form and shape, and we don't have any concerns in that regard.
Sarah, what else?
Well, Chair, we've got a couple of questions here which might be best placed for you or our Chief Exec to answer. How do we plan to overcome the challenges of long waiting lists for mental health support and out of area placements?
Well, I'll just pick up a part answer and then, if I may, hand over to Nick, particularly on out of area placements. I've said to the Council of Governors on previous occasions, and I'll repeat the message today, that our capacity as a provider of services depends critically on the resource that we're allocated by the system. And that in turn depends upon the system recognising that mental health, and I know this applies in many ways also to our community service, but particularly in mental health, it hasn't had the just allocation in the past compared with other conditions that it deserves. Now, that situation has begun to be rectified locally. It's begun to be rectified in terms of the NHS long-term plan, but particularly as thinking is now going into the next phase of NHS financing nationally, I do say to our public, you do need to raise your voice, both locally, perhaps in forums involving your MPs, to say mental health deserves its place. Otherwise, we are constrained by the inadequate resource that we're given. Nick.
Thanks, David. So there are acute and chronic causes for our waiting lists and the number of patients in out of area placements. Historically, there has been a lack of resource for mental health services nationally, and that's been particularly a feature of some of our local services. The good news is that the funding settlement recently is a good deal better than it's been in the past, so we do have more money to invest in mental health services, but obviously we need to look at how we spend that money, and recruitment is a real challenge for us, as it is for many other organisations. So how we staff our services and ensure that we have comprehensive community services is a real priority for us. The out of area issue is complicated by a number of factors, not least the standard of some of our estates, so some of our buildings. We don't have ensuite facilities, particularly in our wards on the Warneford site, which has meant that we've had to reduce the number of beds we've had in operation during the course of the pandemic. Therefore, we've had to reduce capacity, which has led to a number of out of area placements. But also we have a long length of stay in our inpatient mental health services, a length of stay that's far longer than many other trusts in the country. And this again is a reflection of a relative lack of community services, particularly crisis resolution and home treatment services. However, the good news is that we now have resource to develop those services across Buckinghamshire and Oxfordshire, and that's something that we are doing and will continue to do. So I think in the long term things will improve. Key to that is getting the right staffing in place and improving our estate, and that's why building a new hospital on the Warneford site is an absolute priority for us.
What else, Sarah?
We have some questions around staffing. How is Oxford Health going to tackle the challenges of staffing as the pressures on healthcare continue to increase? And a related question about how we're determined to decrease agency costs and convert them to trust substantive staff.
I'm going to hand that one over to Nick, bearing in mind that it's been a subject of some discussion earlier today when the Board of Directors met.
Indeed it was, David, and rightly so. So there's a lot that we are doing, international recruitment being one example, but I think key to this is to ensure that Oxford Health becomes an employer of choice, a place where people want to work and continue to work. To do that, we need to make sure that people feel supported, that they have opportunities to develop their career, that we have a culture in place which empowers and engages and values people at every level in the organisation. And that is work that is in train. There are some practical measures as well in terms of how we can speed up our recruitment processes to reduce the length of time it takes to actually recruit people to vacancies, to ensure that when people start in the organisation, everything's in place from day one in terms of computers and name badges, access to electronic patient record system, all those practical things that sometimes we don't always get right, but are key to ensuring that people want to stay in the medium to long term. We need to have in place a culture whereby people can develop their careers within Oxford Health and can see opportunities for them to grow and progress. We need to develop our leaders, ensure that we manage talent, that we look at succession planning. And this is one of the reasons why I'm really excited by Charmaine's arrival in a couple of weeks. One of the things she's been tasked with is organisational development and making sure that we have a great culture in place, and one which will ensure that we can retain the best talent and recruit the best talent going forward. We also need to work collaboratively with other partner organisations, which we are doing increasingly across Buckinghamshire, Oxfordshire and Berkshire West. And finally, I think we need to be creative and innovative and look at how we can develop new roles to sit alongside traditional roles, whether they be medical roles, nursing roles or whatever. And we're doing that. And Marie Crofts, our chief nurse, has been instrumental in this, along with colleagues in learning and development, looking at apprenticeships and nurse associate roles, etc. And in many ways, Oxford Health has been leading the way in some of this work, and we've been working increasingly closely with the universities that train healthcare professionals of every discipline, particularly Oxford Brookes University. So there's a lot that we are doing, there's more we need to do, but key to me is making sure that we are the organisation that people want to work in, so we can actually have long lists of people wanting to apply for our jobs.
And can I just add to that, or underline a point you are making, Nick? I mean, as a research which is passionate, a trust which is passionate about research, because of our relationship, particularly with the University of Oxford, we hope that people will want to come to us to do research while doing good, excellent clinical practice. And that applies to allied health professionals and to nurses, a point made by Professor Keir Nobre on our board today, as well as to doctors, that they will want to come to Oxford because it's an intellectually exciting place to practice and practice medicine and provide health services. Sarah, what other questions do we have?
We have a couple more questions here, Chair, and they are interlinked. We've recently published the Oxford Health strategy for the next 5 years. And the question here is, do we think that the strategy will lead us to becoming an outstanding trust?
Perhaps I could ask Mike to begin field that one.
Okay, yes, we do indeed. So our vision of outstanding care delivered by an outstanding team is right at the heart of what we do, and that strategy has been set to cover the key elements that will enable us to indeed deliver that. It's been shared across the trust, and all areas of building the detailed plans to enable us to deliver on those. So, for example, in my area, sustainability in particular with the finances, it's really important that we break even in the future to enable us to have a rock solid platform for delivering the actual quality care. So we all work with that, and the operation structures in place to ensure that we can deliver upon that in a methodical way.
Mike Hobbs, you and fellow members of the Council of Governors, in a sense, invigilate our delivery of the strategy. Any observations from you?
I think the energy and vision coming from the board over the past year, including the year in question for this annual meeting, has demonstrated both to employees but also to our service users and carers, and hopefully to the wider public, the determination with which collectively the Trust is going about this strategic vision. It is absolutely critical that we bring Trust members, that's why this meeting is important, staff, and also the wider public along with us for this purpose. And so I'm very much hoping that the Council of Governors collectively and individually will support the programme of engagement within and outside of the Trust in order to secure the support that we need to achieve the vision. It's all very well to have the words, but we have to have the backing and we have to have the means. And that is something I'm sure that everyone here will expect us to address in this year and the coming years.
Sarah, more questions?
Couple more questions here, David. This is in relation to EDI and plans to provide tailored services to the LGBT plus community. Have we any plans? Julian Fitzgerald has asked.
Nick, you perhaps want to pick that up. The networks seem to be going strong. You may want to mention that, but over to you.
So equality, diversity, inclusion is something which is an absolute priority for us, both in terms of our workforce and in terms of how we support the people we serve, particularly to address those health inequalities in relation to people from various minority groups. Now, we don't have plans as such at the present time to develop dedicated services to support the LGBTQ plus population. However, we are very sensitive to the needs of that group and committed to ensuring that our services are aware of any specific needs associated with that group of individuals. What I would say is that, you know, our services have to be designed in conjunction with those who use them. So we're very keen to develop a real sense and a real culture and ethos of co-production. It's not for me or others to impose services which we think others require. It's for us to design the services that people want from us. So going forward, you know, very keen to work more collaboratively, and if the gentleman concerned would like to work with us, that offer would be hugely appreciated.
Thanks. Sarah?
Yes, we have a question here from one of our new elected governors. Karen Squibb-Williams has asked this as a general question in regard to reducing agency costs, which I know we touched on earlier. She has asked, can we signpost where best information can be found regarding our plans and strategy to reduce agency staff use?
Mike, do you want to pick that one up?
Sure.
Yes.
What were you saying, David?
Okay,
Sorry,
go on, Nick.
Thought you might say that, Mike. No, Marie Crofts, who is our chief nurse, has executive responsibility for this, and I'm sure Marie will be very happy to provide further details of the work that has been developed and is now in train. There is, as you would expect, given the importance of this issue, a very comprehensive plan, which we are now keen to deliver at some pace. We have been hindered by the challenges associated with the vaccination program and the need to ensure that that program is effectively staffed for very obvious reasons, given, you know, the absolute centrality of the vaccination program to our response to the pandemic. But now I think we've been able to free up some resource so we can really now focus on reducing agency spend. So Marie, who I know is on the call, although can't join us because of the limits of this sort of webinar function, I'm sure we'll be happy to contact you offline in relation to this.
Thanks. Sarah?
One final question for this segment, I believe, although there are others coming in. It's a question from a member who said, I'm hearing much about Oxford and Buckinghamshire, But what about the BSW, the Baines, Swindon and Wiltshire services? Are we to expect the same initiatives across the board?
Nick will provide chapter and verse, but I'll say from my point of view, absolutely. We work in two integrated care systems, the second being Bath, Swindon and Wiltshire. We're acutely conscious that we have far-flung services as far as Salisbury, and I certainly try and encourage board members to make all efforts to include in our colleagues who are in a geographically dispersed area outside Buckinghamshire and Oxfordshire. Nick?
I would echo what David's just said. Our services in Baines, Swindon and Wiltshire are a very important part of the organisation. We're very proud that despite many challenges, we're delivering some excellent care across those services. In fact, David and myself are attending an engagement event with our Baines, Swindon and Wiltshire staff tomorrow morning, and this last week I had a very important meeting with James Fortune and one of our estate leads, looking at the challenge associated with the estate that we have in Baines, Swindon and Wiltshire, and what we can do to improve that. So yes, those services are a very important part of this trust. And something we are absolutely committed to, and in particular keen to continue to develop and improve.
Can I thank Sarah for comparing that Q&A session, and thank you for putting in a series of very interesting questions, which we're happy to deal with now, but obviously if there's follow-up, and we'll obviously be looking at the chat function, and we'll try and supply additional answers out with the context of this meeting. Now, that's not the end of the accountability function of this evening, but perhaps it would be good for a few moments to look at and celebrate some of the things that we do. And we've organised some presentations. Hopefully they'll be entertaining as well as informative, to sort of showcase some aspects of trust work, both permanent and, in the case of COVID, more recent, and hopefully transient. So our first presentation is indeed a video about our large-scale vaccination centres, which have supported the first era of vaccination and may now be needed, will be needed for the booster programme, and possibly the building in of a permanent protection against COVID. And we look in this video at the success and what goes on behind the scenes in our centres in Reading, Oxford and Aylesbury.
The COVID vaccination programme is one of the biggest challenges the NHS has ever faced, and it was one in which Oxford Health was determined to play a defining role in our region. I am so proud of the team at Oxford Health for what has been achieved, and being the COVID Operations Director, knowing the work carried out has saved countless lives, mums, dads, grandparents, friends and relations, and that it has prevented so many hospitalisations, all helping us back to a new normal. Now, 9 months after this logistically complex work began, we can look back, take stock and have so much pride in the fact that we've administered more than 600,000 vaccines. This work will not stop. With younger age groups now eligible, alongside a booster programme this autumn for our most vulnerable residents and health and social care staff, there will be no let-up in the challenges the team at Oxford Health will face. At our last AGM in September 2020, the second wave of the pandemic was only just beginning to tighten its grip, and hopes of a vaccine seemed such a long way off as we awaited the results of trials. In the meantime, death tolls rose, lockdowns ensued, and swathes of the economy were paralysed as normal life was turned upside down for so many people. By November, it was clear a game changer in the battle against coronavirus was close. In December, Oxford Health was awarded the honour of becoming the lead provider for the large-scale mass vaccination centres. These would be essential in the rapid rollout of vaccinations in Oxfordshire, Buckinghamshire and Berkshire West. These centres would support the work being carried out by other NHS partners, particularly our GP-led primary care networks. It was a time to embark on system working in its truest sense, with other trusts, clinical commissioners, local authorities, support agents and community partners. We were all working together with a common goal. We set up a multi-skilled project team and work immediately began to find suitable venues, ones large enough to cope with our predicted volumes of patients, that were easily accessible and could meet a seemingly endless list of requirements. This included the ability to safely store medicines and enable secure IT network requirements. The biggest challenge perhaps was creating a sustainable staffing model which would not impact on the care we still had to provide on all our hospital wards and out in the community. We couldn't take staff away from their frontline duties, so appeals were made for those recently retired and healthcare professionals to join our ranks via an external agency and been trained in everything around the new vaccine. Teams worked unrelentingly to make preparations, and it was a round-the-clock effort, but everyone gave their absolute all. Each and every one of us knew we had to make it work and work efficiently. I'm sure many of you, or people you know, have had first-hand experience of our vaccination centres at the Cassam Stadium in Oxford, the Gutman Centre in Aylesbury and the Broad Street Mall in Reading. We moved out of the Medeski Stadium when football resumed and the Bucks New University campus when students were returning, so we've operationally stood up 5 centres in all. I'm so delighted that almost 99% of patients who filled an online survey said that they judged their visit to one of our vaccination centres as good or very good. I really hope this video will give you a flavour of how the centres are set up and how they operate, changing and adapting to different patient groups and vaccines as the rollout continues. It will also chart some of the milestone events that have taken place over recent months. But first, let me take you on a tour of the Gutman Centre. This is where our team recently had the honour of vaccinating our Paralympic heroes.
Welcome to the Stoke Mandeville Stadium Mass Vaccination Centre. Our patients are greeted by security as they arrive at the Stoke Mandeville Stadium. Then they are taken through and checked in by the front of house admin team. Once our patients have been checked in, they are guided into our vaccination booths where their vaccines are administered. And then after that, they are guided through to the post-vaccine observation area where they are monitored by healthcare professionals for 15 minutes before they're allowed to leave.
Great. Slightly tempted to observe that using the Kassam Stadium for vaccinations is slightly more profitable use than using it as the home for Oxford United, whose results since they returned to the stadium have not been brilliant. Similarly, actually, in the Majeski and Reading, but that's for another day. Sarah, do we have a chance to put any questions to Mina? Have we had any?
Yes, we have indeed, David. Controversial, I have to say, Oxford United. Yes. General questions about the COVID vaccination programme. So how can younger people get their jab now?
Thank you very much. So there's a number of different ways in which the younger population can get a vaccine. 16 to 17-year-olds should be able to book via the national booking system from Friday, but in the meantime they are able to walk into any of our mass vaccination centres and receive a vaccine. We started today our 12 to 15 programme. We went into 2 schools and it went extremely well, but that will be rolled out over the next 8 to 12 weeks to enable anybody who would like to receive a vaccine who's 12 to 15 to do so.
Good, excellent. Sarah?
Yes, and we've got a question here about the booster vaccines. How is that being administered, and do we feel that this will eventually be offered to everybody?
Thank you. At the moment, the booster programme is being offered to people who were in those previous cohorts 1 to 9, if people remember. So anyone who's 50 or over, our frontline health and care workers, and then anyone in a care home and anybody who is clinically extremely vulnerable. So those people are going to be offered a booster over the next, again, probably 8 to 14 weeks. It's not clear at the moment whether a booster will be offered to people who are 49 or just under 50 or not yet. I think it depends on really what the long-term evaluation is of whether it will make a significant impact to their protection going forward. But at the moment, the booster programme is really only targeted at, as I said, those people who are in cohorts 1 to 9, so over 50, our staff, people in a care home, and then people who are clinically extremely vulnerable.
Do we know yet, Tamina, how that will relate to the flu vaccination programme?
I think it will look quite different in different places. So for the school programme, where possible, co-administering flu and COVID. And I know in primary care, they're looking to see whether they can do something similar, and they usually do their older vulnerable population. For our staff immunisations, we are, as you may be aware, and so hopefully staff are today, rolling out our flu campaign, and there are clinics across the geography of the trust. We're also looking to see whether we can take COVID in at the same time, and also what other options we can do to offer it to staff. Of course, the challenge is that you can't get the booster until you're 6 months plus since your second dose, so sometimes those don't align particularly well in terms of when you might be offered the flu. But at the moment it is possible to co-administer. I suspect some people have the opportunity to do that. Some people would prefer not to, so people can receive the vaccine separately if they'd rather do that.
Other questions, Sarah?
Well, you kind of stole what I was going to say.
Sorry.
It was indeed, how is Oxford Health planning to protect staff with a potential flu and COVID outbreak this winter?
I think that's actually there's a couple of parts to that. So certainly one of the roles of my team is to make sure that we offer our staff a booster as soon as they're eligible, so 6 months after their second dose. I'm also aware that we continue to make sure we follow really good infection prevention control guidelines in our working environments and certainly in our patient-facing areas.
More other questions?
If
not, we can let you off, Tamina, with deep thanks for you and to you and all your colleagues for the work that you have been doing, and I fear you will have to continue to do, not just during the autumn and winter ahead of us, but possibly as a permanent addition to the mass vaccination program that we have in the shape of flu. But let's hope that your work during the next few months won't be too arduous, but we'll leave you this evening with our deep gratitude. Thank you.
Thank you.
Now it's another chance to look at an aspect of our work in the community. You'll know that we provide what are called community services, a vast array of vital health outside the acute hospital setting in the community, in the county of Oxfordshire. And we're going to look now at some of that, some aspects of that, and indeed hear from some of the people that we try to serve.
Good evening, everyone, and thank you for joining today's meeting. My name is Ben Riley and I'm the Executive Managing Director for Primary, Community and Dental Care. I thought it would be helpful to start today's update with a quick recap of the community services our Trust provides to people who live, work or study in Oxfordshire. As you can see, this covers a wide range of activity with many thousands of patients, residents and families receiving care each year. This includes people of all ages and backgrounds, from the very young through to the elderly. Community services are at the centre of the population's health, and this map of Oxfordshire shows where our community hospitals, our outpatient facilities and our urgent ambulatory care centres are located. As care shifts increasingly into the community, we're expecting home-based care to grow in the coming years, particularly as we roll out the new national requirement to respond to older people in their homes within 2 hours of a health or care crisis. This is part of the NHS Ageing Well programme. During the pandemic, all these services have played a major role in maintaining the flow of patients through the system, providing urgent assessments, rehabilitation therapy and expert nursing care. Despite enormous pressures on our workforce, we've seen the average length of stay in our community hospitals significantly reduced over the past 2 years, which is a fantastic achievement for our teams. Over the past year, our 2,000 staff have gone to incredible lengths to keep going, which has been of critical importance for patients. For example, at one stage in the pandemic, our community dental service was the only urgent dental care hub running for several weeks across the southeast of England. That's just one example of many I could give, as so many teams have once again risen to the challenges posed by COVID. And I'd like to use this opportunity on behalf of the Directorate to thank all our staff for their hard work, dedication and the care they've shown to our patients and to each other. I'm delighted to report that several of our teams have been recognised this year through a number of awards, and some examples of the prizes we've won are included here. As well as celebrating the achievements of the past year and recognising the sacrifices made by our staff and their families just to keep things running effectively, I'd like to spend a few minutes to look ahead. This includes updating you on our future plans and the work we've been doing with our system partners, including Oxfordshire Clinical Commissioning Group, Oxfordshire County Council, OUH and our primary care colleagues to develop new longer-term strategies for the community healthcare services in Oxfordshire. The main aims agreed with all the partners for this work are to improve the health and wellbeing outcomes of our residents, to enable our older people to increase their independence for longer, and to make sure we're getting the most benefit that we can from our community healthcare sites, including our community hospitals. To do this, we'll be reviewing a wide range of services, with particular focus on those that support older people, including our urgent care services in our community hospitals, as well as developing our ability to respond more effectively and provide more care in people's own homes. Although the focus at this stage is on older people, we'll also be taking forward work to develop our children and young people's services, recognising that there are some challenges facing these that we need to address if we're to meet the needs of our most vulnerable younger people and families. It's important to highlight that the strategy is a collaborative piece of work with our partners, as well as with our staff and with the public, who'll be consulted on any significant changes before they occur. To guide our decision making, we've drafted 12 principles setting out what sort of changes we'd like to make, as shown here, and we're keen to get as many views as possible on these, as they will be used as a blueprint for the detailed plans that we'll go on to develop for each service in the coming months. We need ideas and suggestions from a wide range of people, and have already started a programme of discussion events with staff and with the Trust governors. We'll also be holding a number of public engagement events online, which everyone's welcome to join. If you'd like to participate, please visit the webpage shown here, where we'll be posting information on how to take part. Thanks for your time today. To finish, I'd like to share with you a patient story from an older gentleman who was an inpatient in one of our community hospitals. In the following video, he describes his experience of COVID, the very sad impact it's had on him and his family, and the care he's received. And his story reminds us all why we're here and why our teams work so hard to provide excellent care for people.
was transferred straight away to the JR. My wife went in at the same time virtually. A few hours later, unfortunately, she died within 24 hours. I've been into the JR intensive care unit. I was there for probably 2 months in a coma of sorts. For those people who say it's or sort of downplay the COVID thing, it is awful, really awful. And although I'm making good progress, I'm still not able to walk, I'm not able to dress myself or anything like that. And I'm having physio and all that sort of thing now. You know, caring, they know how far to go with things, and in particular physio, which is I find very difficult, but everybody does apparently. Now, I've got nothing but good to say about all of the units I've been in. In particular here, they've allowed me, one of my 4 sons comes in every day to see me. He lives in Stoke, which is just down the road. That's been ever so good. They've allowed one of my other sons to bring my 2 little dogs and have them outside the window. The consultant once a week, he comes round, has a chat, very wise person, doesn't spin a line, tells you as it is, and I can ask him any questions I like, so that's good. And the nurses are very well informed on what my history is since I came in. So on the ball with everything, but even down to library books being brought in, and use of an iPad, that sort of thing. It's good. It's good. Couldn't have asked for better.
That very moving patient account seemed to epitomise what community care is all about, and indeed one of the glories of the Oxfordshire system is still have units like that where the local community sort of exist in and around our provision. Now, we've got a chance to put some questions and make some observations to Dr. Ben Riley, Director of Community Services. Sarah, do we have any points to put to Ben?
Yes, we do, Chair. In reference to the plans for the future, can we give examples of the improvements to increase independence for older people?
Hi there. Yes, there's a number of ways that we're looking to do that really, and the detailed plans, of course, will be worked up with staff in services as well, and with patient involvement. The sorts of examples I think we're particularly looking at is around about getting patients back home as soon as we can, because there's lots of evidence that shows that if people are cared for in their own home, that they tend to have better long-term outcomes, and it sort of maintains that independence really. There's a new service being rolled out across the county called the Urgent Community Response, which is a requirement to respond within 2 hours of a care or a health crisis being identified in a person who would otherwise potentially need to go into hospital. We're also increasing the amount of staff and resources that are going to home reablement across the system really, and also therapy as well. And also within our community hospitals, we're looking at ways that we could increase the focus on rehabilitation and getting people home as sooner as we can, and sort of breaking down that boundary that exists between the inpatient unit and the care at home, so we can make that as seamless as possible. But there's just some of the examples. Another really important one as well, actually, of course, is preventative care, and how we can delay the time at which older people lose that independence or become reliant on services or institutions, such as having to be in a care home, when, you know, if you speak to most older people, they'd much rather be at home as long as possible.
Other points, Sarah?
Yes, we've covered older people as a question here about how we plan to improve community services for children and young people.
Yeah, so children and young people are another really important group for us. So if you look at our services as a whole, you know, these are the two big users of community services, really. In terms of the areas of priority there, I think that there's going to be some work on the universal offer for the 0 to 5-year-olds in particular. That's part of the Start Well part of the Oxfordshire strategy. So that's looking at things like health visiting services, the best start in life, because we do know that those early years are really important. Another really important group is the children we care for, or looked after children as they're sometimes known. That's become particularly relevant in the last few weeks, actually, when we've seen refugees from Afghanistan coming over to the UK, for example. And I think children's mental health is another area where we're going to have to prioritise in the broadest sense, because I think there's recognition now that children's mental health needs to be thought of more as a system-wide issue, you know, involving schools, families, mental health, and all sorts of health services, really, and the third sector. And it's not a problem that can just be, you know, picked up by specialist mental health services. So there's some of the areas that we'd be particularly focusing on there.
Have you time for another question, Sarah?
We do have a time for one more question. Yes, it comes from Melissa Clements, who is one of our public governors for Oxfordshire. And she says, Ben, could you please elaborate on how you plan to reach all demographic groups with your communications? In particular, I'm interested to hear about those who may not be keen or able to use websites and emails. We have, of course, got these virtual events planned.
Yeah, that's a really important question, I think, and obviously in the context of COVID, even more relevant, really, because whereas in the past we would have had, you know, more public meetings, there is a need to do that on an online basis where we can, because of the infection control issues. But having said that, we do need to focus on how we can reach people from all backgrounds, and one of the ways we're going to do that is look at, through our services, how we can contact people that are actually using the services. So, for example, in community hospitals or home visits, and actually, speak to the patients directly and get their views that way, and develop questionnaires or surveys and things that we can actually roll out through the services themselves. We'll also be, tracking the sorts of feedback that we get and the different demographic groups who we have had responses from, so we can see if we have got gaps and then target those as well.
Thank you, Sarah, and thank you very much, Ben Riley, for that presentation. We've now got a chance to showcase one dimension of the Trust work which we do feel is distinctive, and that is our connection with particularly the University of Oxford in the endeavour to apply new knowledge to the better care of patients. We often use this phrase R&D, research and development. It's sometimes worth stressing the second of those developments. New knowledge is great, but it's new knowledge that we can help translate into improving the clinical practice of our consultants, doctors, nurses, and so on. We're going to hear now from Dr. Carl Marlowe, our Chief Medical Officer, who is, for the time being, also our Head of Research and Development, and with great pride, from one of our own consultants, Professor Belinda Lennox, who's shortly taking over as Director of the University of Oxford's Department of Psychiatry. Carl.
Thank you, David, and welcome everyone this evening. If I can go on to my first slide. Well, research is central for what we do in Oxford Health, and has had to be adapted through the pandemic in the last 18 months. So since March 2020, we were quite worried about how research and development and how our projects would continue. But actually, these, despite the restrictions, projects within our R&D department have flourished. Some staff were redeployed, but we continue to deliver research studies, and some 47 new research projects opened between March 2020 and 2021. and 10 of these were directly related to pandemic endeavours. So I go on to the second slide. We pivoted to the urgent public health needs during the pandemic. We worked across the National Institute of Healthcare Research in the Thames Valley. We worked in partnership with our clinical research networks, which is a large research network in our area of the Thames Valley and Wessex. And we worked in collaboration with the University of Oxford's General Institute, and we hosted critical vaccine studies. We were one of 33 national sites which hosted a Novavax vaccination study with 462 patients and participants recruited. And the early results from this study showed that this Novavax vaccine was 90% effective. There's going to be ongoing publications which results are going to be followed up. If I go on to the third slide. So another great aspect of our work in Oxford Health is that we host the Oxford Health Biomedical Research Centre, which focuses on mental health. And this centre has been able to continue doing important research, especially focusing on mental health. For example, there was the project by Professor Cathy Creswell, which looked at the COVID impact, in particular with children and young people. There is a study by Professor Andrea Cipriani, which was building an evidence base with regards to telepsychiatry being rolled out, and has been followed not just here in the UK, but also internationally. We've also had projects by Professor Paul Harrison, which looked at a link between COVID and early mental health diagnosis, which had a very significant national profile. We've also had the project by Daniel Freeman, which was looking at treating needle phobia in order to decrease vaccine hesitancy. And that initial project showed a 10% decrease in vaccine hesitancy in those individuals, very relevant to public health needs. So the next slide, please. So as well as being keeping research going, we're moving forward with greater momentum on our research and development ambitions at Oxford Health. One of these has been to increase access to research projects and to increase inclusivity so that all patients who are in contact with us have the opportunity to benefit from taking part in research. So following on from the initial project, which started in 2019, in August this year, we implemented the Count Me In initiative in the way we contact people to invite them to take part in research who within the wider scope of the BRC and all the other research projects that we're involved with. This way of involving patients is this way of involving patients in terms of contacting them within Oxford Health is being followed by other organisations within the NHS, and we expect that this may become the model of how people are involved in research. Next slide, please. Another highlight with regards to, you can see in that building, has been the opening of our Oxford Health Brain Health Centre, which opened in August 2020 after the first lockdown. This is an integration of research and clinical services, and it's also a model of how the University of Oxford and Oxford Health can come together in order to push forward and to show that research can lead to patient benefit, and as David mentioned just now, early translation. I will go on after the slide to show a short film which shows the work of this centre in practice. Can we roll that?
research is really important. Clinical research is really important for all of our mental health services. It's the only way that we get to know what helps people and to help understand the causes of why people have become unwell when they have. So being active in research is really important for every NHS hospital, and for all patients to be aware of research that's going on in their organisation. The Brain Health Centre is an excellent example of bringing research into clinical practice and really making a difference to people.
So when patients arrive for their Brain Health Centre appointment, they'll be met by a member of our staff who will welcome them in, will sit down and have an introduction to why they're at their appointment today. We'll then talk through the research options that we offer at the Brain Health Centre whilst they're at their clinical appointment. They can consent to a range of research options at the Brain Health Centre, all optional, but luckily many of our patients take part, which is fabulous. Once the consent process is complete, we go to prepare the patient for the MRI scan. The patient and their relative will go to the dressing room. The patient will get changed into some metal-free pyjamas so they're comfortable in the scanner. And once changed, the radiographer will come and meet them. The radiographer will go through some MRI safety questions with the patient and their relative just to confirm everything's safe to go in the MRI scanner. Then we'll take the patient through to the MRI scanner. The patient will be given some earplugs to protect their ears from the noise of the scanner. They'll lie flat on the bed. They're given cushions, some blankets to make sure they're very comfortable. And then the patient slowly moves into the scanner itself and the scan will begin. The scan takes around 15 minutes for the clinical part of the scan. If they agree to take part in some additional research scans, it's an additional 15 minutes in the scanner. So once the scan is finished, the patient will come out, get changed back into their own clothes, and then we'll go to complete some neuropsychological assessments. So that takes around half an hour, and that's part of the clinical assessment. Then if they've consented to give a saliva sample, they will provide us with that saliva sample.
The Brain Health Centre is integrated clinical research infrastructure to enable patients to be given the best possible assessments as part of their memory clinic appointment, and to create, we kind of call it a translational interface, so that the research that we're doing within the university can be most easily and most quickly translated into benefits for patients. So we want the research that we do to be relevant to all patients. But typically the way that we've done research in the past is to select a small group of patients and invite them to participate in a particular study. That means that the research that we do is only done on that small minority, and that might mean that it's not relevant to the full patient population.
Patients do benefit from the setup of the Brain Health Centre. It has been a great opportunity to empower the diagnosis of dementia and empower our patients. They had been part of how the Brain Health Centre had been set up. They had the feedback so far had been extremely positive, and there are very great benefits for patients and for clinicians.
Fascinating. Do we have the chance, Sarah, to put some questions to Linda and Carl?
apologies, on mute. Yes, we do have some questions coming in, David. The first is, what steps is the Trust taking to ensure that all patients and service users are able to understand and act on their choices regarding how their patient information is used in any trust-based or national research projects?
Belinda, Carl, do you want to pick that one up?
I might hand over to Belinda if you want to. It's a very technical question.
It's obviously important because of sensitivities around patient data. Belinda.
Of course, well, it's a very live issue as well at the moment. So, and the rules are sort of being consulted on, aren't they, about the ability to opt out of data sharing and all the rest of it. So it's actually broader than Oxford Health. But I mean, I suppose the principle, certainly in all of our research, is that no one's information is used, no patient is contacted without the express consent to do that. So I suppose, to put it on the other side, I suppose it's also important, I would say, that people are given the opportunity to take part in research, so that actually they are given the information to take part if they do want to, and to say no if they don't want to. So it's a balance between making sure that opportunities are available, and also, of course, that people's data is kept private and secure. Is that a bit of a wishy-washy answer? Sorry.
So as a Caldicott Guardian, I have a particular interest in patient confidentiality, but it's also the balance of making sure that we're able to provide research which changes people's lives, especially in mental health. But it's a technical question, but something that we consider in great detail within this trust.
Sarah, anything else?
Yes, another question. It's also in relation to the opt-out, which is, what is the mechanism used to contact patients without disregarding patient consent, as well as DPA and GDPR? Where is the patient data drawn from?
So again, a very technical question. I wanted to say that we don't know all the technical questions, but if the individual wants to contact me directly, we can get our data protection officer and our team to get back to you and show you that we consider these things in great detail. And I'd rather not give an answer which is technically not right. So for that technical question about the GDPR, I would like to say to anyone tuning into this today that it's considered in great detail, especially with research, and all research governance also looks at anonymization to make sure that people's details are not used inappropriately.
Thank you. Moving on to perhaps easier questions, Chair. The Brain Health Centre looks really interesting, one of our attendees has written. Are there any other examples of collaborations between the Trust and the university?
Do you want to take that, Carl? Yes,
please.
Absolutely. The Brain Health Centre is a great example, but I'm pleased to say that there are many more examples across the lifespan and across the different services, and plans to expand greatly and increase those collaborations. So we're right in the middle of applying for our renewal of our Biomedical Research Centre, which hopefully will increase the scale of it, by 4 times. So we want to reach every bit of the organisation. That's our plan.
And am I permitted to add, our relations with the university are not just brilliant, though they are, through the Department of Psychiatry. We have good research relationships with the Department of General Practice, with colleague clinical psychologists, and indeed with colleagues who study health organisations in the side business school and other parts of the university. So I hope our relations with the university are multitudinous and enriching on both sides, and not just, great though they are, not just with the Department of Psychiatry.
just to add one thing, David, our work in Oxford Health is also to build networks of collaboration right across other institutions as well, and other NHS organisations. To answer the question, we are working currently on a children's and young people's university-based research service, which will be looking at supporting children and young peoples with regards to psychological therapies and interventions.
Time for anything else, Sarah? Or
I think we're out of time for this segment. Thanks, Dave.
Keeper of the clock. In which case, we need to move, thanking Belinda and Carl very much, to our fourth and final presentation this evening. And with this, we're in Buckinghamshire, and we're going to look at a prize-winning service that tries to support mothers who may have mental health conditions before, during and after their pregnancy. We've heard from the board recently from patients who've been in this service, and it's a great story. So look forward to this. Thanks.
We're a specialist service, and we work with women from conception right through to a year postpartum. Then we're looking to expand upon that. We're made up from a mixture of professionals. We have a full-time psychiatrist, a pharmacist, a psychologist. We have nursery nurses, community psychiatric nurses, an occupational therapist. We have social workers. We have nursery nurses, a peer support worker, and a mind support worker. So we're quite a comprehensive team. We work really closely with maternity services, so your health visitors, your midwives, your GPs and things like that, and that's where we get most of our referrals from. So we work with women with a range of mental disorders, ranging from postnatal depression and anxiety, anxiety and depression through the pregnancy, obsessive compulsive disorder, birth trauma, right through to things like bipolar type 1 disorder and schizophrenia and postpartum psychosis, which are at the more kind of serious end. 1 in 10 women will experience a mental health disorder during the perinatal period, and quite shockingly, suicide is the leading cause of death through that period as well. So that's kind of why we're here, really, to make a difference. Untreated perinatal mental illness can have a really long-term impact on mothers, babies, and the whole family going forward. So that early intervention can make a real difference. And the one thing I would say is it's really treatable. So seek help where you can.
I work in lots of different ways with mums, sometimes behind the scenes supporting the staff in the work that they do, but also in some cases I work directly, and that'll either be in a group format or one-to-one. So from the group's perspective, we run a compassion and focused therapy group. So it's a small number of mums, usually about 9 or 10 mums, who meet over 12 weeks, and we just teach them some of the principles of compassion focused therapy and then help them to apply that. And it's got a strong evidence base to support mums in this adjustment and time around the perinatal period in building up some really helpful resources and skills for managing their well-being.
So if anyone's experiencing any mental health problems or any concerns, I'd recommend that they see a professional. So that's either their GP, midwife, health visitor, who can refer into our service. So we accept referrals from any professionals. And from there we offer an assessment and a range of services. So we have psychology, which can be one-to-one services or group therapy. We have a psychiatrist who can offer medication advice and pre-birth planning. So we run a variety of groups. We run a circle of security group for mums to learn about the relationship with their babies and to aid bonding and attachment.
It helps the mums to keep the babies in mind, to look through the eyes of the child,
and helps with their connection, so that they get a secure bond with their babies. We get a lot of mums that are really anxious, think they're not doing a good job. It's a good way to demonstrate to them that they actually are doing way better than they think. We also get lots of mums who would like some strategies to help them deal with incidents that crop up with their babies. So we can give them advice and support with that as well, to help them to manage their babies more effectively and understand their emotions.
We have a walking group to get mums active and out there. It's often difficult and quite isolating being a new mum, so getting out and meeting people really does help.
So I am the mind support worker and I work one-to-one with the ladies. I also run 2 walking groups, and the idea about that is just to get people back out of their house, walking around in nature, and we just do one-to-one talking. So I do run 2 of those a week.
As well as the group, I also do one-to-one support with mums, and that's where that level of input is recognised as being needed, and that will either be around potentially trauma they've experienced perhaps during the perinatal period, perhaps around the birth, but also it may be that there's been traumatic experiences earlier on, sometimes in early years in childhood, and at other times later on, that really the sort of journey of motherhood is sort of pulling on, and sometimes the adjustments of motherhood can bring us back reminders of times that we've actually felt like we've sort of left behind or forgotten. So I will do some work around that. I'm trained in a number of different models. I often use something called EMDR, which is eye movement desensitization reprocessing. Also models of CBT, which is cognitive behaviour therapy, and as I've said, CFT, which is compassion focused therapy. We also, as a service, and I use it as well, we're trained in VIG, so that's video interaction guidance. So myself, nursery nurse and one of the care coordinators are trained, and our peer support worker are trained, and video interaction guidance just looks at taking some video of a mum or father and baby playing, and then we go back and just sort of pick out the wonderful bits of it really, and then look at that together with mum or mum and dad, and just sort of notice these moments of connection and attunement between mum and baby. And attunement is just a fancy word for saying that connection, that moment when mum and baby are really sort of focused either on each other or on the same thing. And it's a strength-based therapy aimed at really building on those connections and those strengths. So there's a whole host of different things, many I've not even mentioned, that we can apply either collectively as a team or myself individually. And yeah, it's just about coming in and meeting us and seeing what we can do. We offer an individualised treatment plan, so just to sort of meet the needs of each presenting case.
COVID was a really difficult time for our service, as it has been for many services. The impact was great on our service user group, but I mean, maternity services had limitations on partners attending scans and even attending the birth at times. So that was really difficult for our ladies who were increasingly worried about the pandemic, the vaccines. They were isolated through shielding, and they weren't able to spend time with close family members who would normally be there to support them. So that was really difficult. We had to be quite creative and innovative and get our services running online quite quickly. So we developed an online drop-in group for women to attend, so they could come online and they'd know that there was someone there every day or just once in a while whenever they needed to give them that support. We offered telepsychiatry, so appointments via Teams, and it seemed to work really well as offering face-to-face visits where clinically the risk was quite high. Since then, we are back to more of a hybrid model, so we are, getting up and running groups, but we are keeping things online for those who prefer it. So around this difficult time, we were fortunate enough to be awarded the South East Region Parliamentary Award for Excellence in Mental Health, and that was a real boost for the morale of our team through the pandemic, and it was a real testament to the hard work and dedication of the team. So just a take-home message for professionals and anybody that wants to be referred to our service, I'd say we have a duty worker that works 9 till 5 Monday to Friday, If you've got any concerns about any of your patients, feel free to phone in and talk to us. We're there to help and not judge.
Now we've got a few minutes to perhaps answer some questions that you might have about the Buckinghamshire Perinatal Service. We have with us Lisa Manser, who you saw in the film, and Joseph Madamombe from the service. Sarah, do we have any questions or points? You're on mute.
Apologies. Yes, a couple of questions and an observation. An observation from Governor Karen Squibb-Williams, who said, Lisa and Joseph, this is a wonderful project, and she hopes that we're well enough resourced to ensure GPs and antenatal services, etc., are fully aware of your work. On to a question. What does an assessment with the perinatal services team involve?
Lisa, Joseph, do you want to pick that up?
Sorry, I think you got frozen there, Sarah.
The question, if you can hear me, is what does the assessment with the perinatal team, what does that involve?
Okay, so with our assessment, we do quite a holistic assessment, quite comprehensive. We've got duty workers, either nurse by background, we've got social workers by background, and sometimes that involve our consultant psychiatrist. So it is quite thorough as an assessment. It's different from your generic adult mental health assessment. We're looking at things like red flags, we're looking at the child, we're looking at everything that concerns the family. So it's very, very comprehensive assessment that we do.
Thank you. Final question, I think here, Chair. How long is the period of support provided, and what would they then be referred to? Secondary care services, or will the entire support be based in the sphere of primary care?
Okay. So we do offer quite a range of support. I'll let Lisa speak in a minute. We've got necessary nurses in the team. We've got clinical psychologists. We've got consultant psychiatrists. So it just depends on the mum. So we don't have a fixed period that we support. We have support mum, but we are at the moment commissioned to support women up to the first birthday of the child. And after that, we can signpost to other services if required, or discharge to GP. We work quite closely with midwives, health visitors, and other services, social care, social services. But I'll let Lisa just step in and
the amount of time that we spend with a mum varies, and it's totally dependent on individual needs. So sometimes we might just dip in for a couple of months whilst people stabilise, and then signpost them on to other appropriate services, and other times we might be involved for like the whole year until their baby's a year old. So we tend to refer on to places like Bucks Healthy Minds, or it might be for further psychology. But again, we look at each individual case and refer them accordingly. And then they know that, you know, if they get pregnant again in the future, that they come back into our service with some preconceptual advice if that's required, so that we are prepared for them coming into the next pregnancy.
And the other thing that we've done, we do make exceptions. So we've kept some women, if required, beyond the first birthday of the child. Sometimes women do fall pregnant again whilst they're with our service, or we just feel it's not the right point to discharge them to another service or signpost to other services. So, or they've got the need to continue with psychological input from our clinical psychologists. So again, that's something that we do as a team. We look at an individual.
Thank you very much.
Thank you, Joseph and Lisa, very much, and congratulations again for the Parliamentary Health Service Mental Health Excellence Award that you won. Now, before we finish, your chair is remiss. We do have one piece of business which I neglected earlier, forgive me. If there are any issues with the minutes of the meeting that we held last year, please notify us and we'll amend accordingly. I'm sorry, I should have asked you that at the beginning of the meeting, but I was assuming that you'd had the chance to have a look and approve last year's minutes. A piece of business, but a piece of business that's sort of important. And I suppose I'll leave with this thought that some of this evening has had to be business, yes. Process we've had to hear about, our accounts, our financial situation and so on. And the reason I repeat is because we need to be accountable to you through the Council of Governors, through our members, to the public, which provide the wherewithal for our services. So it is very important. And I'd like to congratulate Iain from Grant Thornton for what I thought was an amazingly clear presentation of some quite technical, but again, very, very important detail around the external auditing of our accounts. And before I finish, again, deep thanks to Mike Hobbs, our lead governor, who voluntarily carries a large burden in terms of making the governance, to use that word, the governance structure of the trust work. We are a foundation trust, and as such, we do have this perhaps unique way of securing a line of accountability to our staff, to our service users, to the people who live in the areas that we serve. And the articulation of that accountability really goes through the Council of Governors and Mike in particular. But we've also this evening had the chance to look at and celebrate, as I said earlier, showcase some fantastic aspects of what is, let's face it, a hugely various set of activities that we do, from brain research through to perinatal services, through to podiatry, school nursing, and all the services that come under the rubric of community services, as well, of course, as providing mainstream mental health services. So I hope you found this evening informative. I hope it's had some entertaining moments and you'll take that celebration of the trust into the regular updating of accountability through members and governors. Some information on the slides, but just before we close, again, I'd like to thank all of you who've made a contribution to this evening, whether in person or through your contribution to the videos. And again, a deep thanks to Sarah and the team for making this run, technologically speaking, extremely smoothly. Thank you very much, and I'll see you all again very soon. Bye.